This is an ABC podcast.
Hello and welcome to the Health Report with me, Norman Swan. Today, tracking the spread and mutation of the COVID-19 virus. An intensive care specialist sounds the alarm for hospitals, and over the weekend, the Australian government intensified its travel restrictions to reduce the spread of SARS-CoV-2. All overseas visitors are now required to self-isolate for 2 weeks upon arrival in Australia. That's on top of banning foreign nationals from mainland China, Iran, South Korea and Italy. But how effective are these bans and when can we lift them? And is self-isolation even the right term? Professor Raina McIntyre has modelled the effectiveness of those very first travel bans from mainland China, brought in on February 1st. Raina is head of the Biosecurity Programme at the Kirby Institute at the University of New South Wales and joined us now via Skype. Welcome back to the Health Report. Third time, I think, Raina.
Thanks, Norman.
So you modelled 3 different scenarios for this, didn't you?
Yes, and this is not published work. I have to say that up front. So it's not peer-reviewed. It's just.
But nor is very much that we're looking at in this area at the moment because everything is going to press so quickly.
Yes, so I can only talk in general kind of principles, but basically travel is the main vector for spread of infections around the world. So anything you do to reduce or restrict travel will have an impact on epidemics. And, looking particularly at the ban on travel that was implemented on the 1st of February in Australia for travellers from China, it appears to have been very effective. So it was a good call. And however, now we're seeing that Europe is the epicenter of the pandemic, and that's thrown up a whole lot of other interesting questions.
So how did you do this study?
Well, we basically just looked at the number of travellers between China and Australia, the frequency of travel, the number of cases that were occurring in China at the time, and the risk of an importation occurring based on that. We also modelled the probable epidemic in China, given that there probably was some under-ascertainment of cases.
And so you looked at a model of a scenario where there was no ban. Then scenario 2 was the current ban followed by a full lifting, and then a partial lifting to allow the university students to enter Australia, but not the tourists. And what did each one of those scenarios tell you?
So if we hadn't, the main finding, the bottom line finding is if we had not implemented that ban, we would have been in a much worse situation, would have had a much larger epidemic. But we also included measures like isolating all the cases, which is what we've been doing, and tracking all the contacts. It's quite important to realise that those measures, the quarantine of contacts and the isolation of cases, are also very influential in control of epidemics, whatever disease you look at. And we've published papers on different infections. We did a modelling study of smallpox, which is also a respiratory transmissible disease, has a similar incubation period, and you use the same kind of control measures. And that showed that if you don't isolate the majority of cases, and if you don't track and quarantine the contacts, either of those things can make the epidemic blow out.
And the key here, one of the keys here is when you take your foot off the brake, and so you modelled a partial lifting of the ban. What would that have done?
Well, if there's very few cases occurring in the source country at the time, then you can kind of look at, phased approaches to lifting bans, but I think it's all kind of, the question is redundant now because the total number of new cases per day in the world has far exceeded now the total number of daily cases, the peak of the Chinese epidemic. So the number of cases that we had at the very peak of the epidemic in China has been far exceeded now by the global number of cases.
What do you think
per day?
What do you think of the policy announced by the Prime Minister, and I think it's also similar to the policy in New Zealand, where people self-isolate? And in fact, I think you think that's the wrong term. It's actually quarantine them. We'll come back to the terminology in a minute, but they go home and they don't go out and they stay isolated in their own home. How effective is that compared to just banning the entry of people from countries like America and overseas?
Look, I think if we can ensure that people follow the self-quarantine, it is an effective measure. Basically, you're stopping people, walking around in the community when they could be infectious. Whichever the measure you're using, whether it's, whatever social distancing measure you're using, you're trying to just stop people having contact with each other when there are potentially infected people around.
Let's just talk about the terminology, because I think the government's probably using the wrong terminology, aren't they, when they talk about self-isolation?
Look, I think it's okay to use sort of colloquial terminology that people understand. It's probably, just that people understand isolation. But the technical terminology from a disease control point of view is that you use the word isolation for a person who's sick, so they get isolated in a hospital bed in the hospital, and you use the word quarantine for someone who's well but at risk of infection because they've either been a contact or they've travelled to a high-risk zone, and they're a well person being quarantined and monitored to see if they develop symptoms.
So in fact, Tom Hanks and his wife and Peter Dutton were isolated, whereas if you've got off the plane, you're quarantined.
Those are the technical words. But I think it's okay to use terminology that general people in the community would sort of relate to and understand.
What's the risk in China of a second wave, that they let the brakes off too soon?
Well, we haven't even had our first wave yet, Norman. We're still very much on the sharp upswing of cases.
That's in Australia, but I'm talking about China.
Yeah. Oh, absolutely. So less than 1%. Even if you assume that there's more than 100 times more cases than they actually documented, it's still less than 1% of their population that got infected. So the majority of the population in China is still susceptible to the infection, and a second wave could easily occur.
Where do you sit with this curious British policy of herd immunity? I mean, there's two ways of getting herd immunity. That's immunity in the general population. One is immunisation. Well, we haven't got that for COVID-19. And the other is to allow X percentage of the population to be infected and recover, and therefore it burns itself out. Where do you sit with that?
Yeah. So I don't think that's a good approach. Firstly, the concept of herd immunity arose from vaccination, not from infection. So the concept itself relates to vaccination. That's what we're trying to do when we vaccinate people, say for measles or polio. We're trying to get enough people immune in the community in a population so that it can't be transmitted even in the people who are not vaccinated. And it relates to how infectious the disease is. So in the case of COVID-19, we think one person might infect 2 to 3 other people, and that's called the reproductive number, the number of people that one infected person will infect if they're completely non-immune. And therefore, there's a mathematical formula. I won't bore you with that, but there's a mathematical formula for which you can calculate the percentage of people who need to be vaccinated to be immune to achieve herd immunity. So for COVID-19, if we go with 2.6, which is the figure we've heard from the Australian estimates, then you're going to need 61% of the population to be immune to achieve herd immunity. Now,
a lot of people are going to die along the way.
Besides which, I think about half the Australian population is aged 40 and over. So to achieve 61% of people infected, you're looking at a worst-case scenario, considering that China had less than 1% of their population infected, and Italy is nowhere near 61%.
It's unrealistic. We are running out of time. Just very quickly, the New South Wales Health Minister said this afternoon that there's exponential growth in New South Wales, which is what we've been saying over the weekend. Should we be shutting schools, cafes, bars right now?
I think anything that we can do to reduce the contact of people with each other will help. It's particularly important. The social distancing is particularly important with this infection because there is the potential for transmission from people who don't have any symptoms. It's much easier to control a disease where it's only infectious with symptoms, and you can get away with less social distancing. But for something where there's no symptoms, where people can transmit it without symptoms, the social distancing measures become even more important.
Raina, thank you.
It's a pleasure.
Professor Raina McIntyre is head of the Biosecurity Programme at the Kirby Institute at the University of New South Wales. And you're listening to RN's Health Report with me, Norman Swan. One of the keys to combating COVID-19 has been the rapid sharing of scientific information between teams across countries. Part of that effort has been building a genetic family tree of SARS-CoV-2, the virus that causes COVID-19, which could help answer questions like how it's mutating and whether it could be becoming more virulent. This revolutionary so-called phylogenetic tree is being built through a platform called NextStrain, which brings together all of the data collected by scientists in one place. Dr. James Hadfield is a New Zealand phylogeneticist based at the Bedford Lab in Seattle, who works on the NextStrain platform, and I spoke to him earlier.
Scientists from around the world, so currently we've got over 500 genomes from over 33 countries, so really amazing credit to all of the people that are sharing this data. They are all generating the data themselves, and they're sharing it through this platform called GISAID, which was set up for sort of rapid sharing of influenza or influenza-like data. And then we go from there and run the phylogenetic analyses.
What does that mean?
So we take those 500 odd genomes that we've got at the moment, and we run mathematical modelling and infer the family tree, if you will, of how are those 500 genomes related to each other, because as time goes on, mutations arise in the genome just naturally through replication, and we use those mutations as signatures to inform which came before another one and which are more related to another. So from that, we can learn about the spread across the world and through space and through time.
And particularly through time, because you can almost time it back to how many replications there's been of that particular virus over time and say, well, that's 3 months old, it goes back to November, or it might go back to 2018 or whatever the story might be.
Yeah, so all of the genomes that are being shared are time-stamped, if you will. That we know when the sample was collected from that patient. And so we know what the date of the samples, but what we can actually do is go back in time and see when their ancestors lived. So we can do things like date when was the most probable time that the zoonosis happened. So that's, for example, the first jump from an animal reservoir into the human population. And date other sort of important events such as transmissions into countries and so on and so forth.
Let's start at the beginning. Do you know for sure that it started in bats in Wuhan?
What we can say is that the evidence very, very strongly points to a single jump from a non-human reservoir into the human population. We know that the closest relative, if you will, of this virus that we have from samples is bats, but we date the closest ancestor that we have, which was sampled from a bat, to be anywhere in the 1900s.
My God, that could be a long time ago.
It could be a long time ago, but what you're really seeing there is actually just a lack of sampling of the bat population. These viruses are sort of endemic in bat populations. And so what that is really telling you is absolutely nothing to do with when it jumped into the human population for this time. So we can say that it's highly probable that this virus did live in bats, but whether it was a direct transmission from bats into the human population or whether it came through another animal intermediate, such as in the case of SARS, we can't say that with any confidence.
And what about the seafood market? Are you able, through your genomic studies, to tie it down to the seafood market, the wet market?
The genomic data strongly supports the seafood market as an amplification event. We still are not completely sure about whether that was the first introduction or whether or not maybe it was around a little bit before then but made it to the seafood market and then that really amplified the spread.
And I've seen somewhere from your data that maybe November was the first case?
The first case or symptomatic case is dated at the very start of December, but the genomic evidence points to an origin or a zoonosis somewhere in the second half of November.
The Chinese, or some Chinese, are saying this was deliberately introduced by the United States Army scientists who've deliberately released a bioengineered organism. Is there any evidence for or against that?
It's quite a good time for conspiracy theories at the moment. What I can say is that all evidence is completely parsimonious with a single zoonotic event that happened in Wuhan in China. So all of the data is completely consistent with that.
And when you say parsimonious, it's focused on that. There's no error around either side of it.
There's absolutely no data out there which would support any other theory.
What's happened to it since? Because we had what I think was a bit of a furphy where a Chinese group said, oh, you've got a divergence between two types, an L and an S, and the L was more virulent, and you had somebody in the Gold Coast in Australia who had two at the same time, and that's been a bit debunked. Where do we sit since then with divergence.
Yeah, so there is absolutely divergence. And by divergence, what we mean here is mutation. So just changes in the RNA genome that arise completely naturally through replication cycles.
But the question is, does that have any functional meaning?
That is the million-dollar question. And the golden rule of phylogenetics, which is what I study, is that if it looks like the virus is behaving differently, 99% of the time it's because of epidemiology. There's absolutely no data yet that there are mutations out there that have any change in virulence or change in transmissibility.
So when you say epidemiology, you mean there might be large clusters of people cramming together and you've got rapid spread, but it's simply because of the way people behave rather than the behaviour of the virus?
You can imagine that if you were to get to let's say a new location, and you just so happen to have a mutation at that time, and that spreads rapidly in that new location, then it's going to look like perhaps that mutation drove the spread through that city, whereas in actual case, it's just a complete chance event that is then inherited by the spread through that city.
And when you look at Italy, South Korea, Iran, and other places, can you tell where the virus came from?
We know that worldwide there are thousands and thousands of cases, but we only have currently 500 genomes. Now, actually having 500 genomes is brilliant and a credit to everybody involved, but it is a very small fraction of the total number of cases out there. So we can make some inferences with a reasonable amount of confidence, but for big questions such as how did it get to Italy, we're missing some crucial links. It probably got there from China, but it's very hard to say absolutely conclusively at the moment. What we can say is that introduction into Italy looks like there was one main introduction which has been growing in Italy, spreading throughout the community in the north of Italy, and that has seeded transmissions into plenty of other countries throughout Europe and throughout the world.
Now, your group was able to show in Washington state that there was an introduction and then 6 weeks of underground, or 3 to 6 weeks, I can't remember exactly now, of under-the-radar replication of the virus before it became obvious. Do you have a date, if you like, when it might have started in Italy, similar to you had a date in Washington state?
We have dates that are sort of around about the middle of January, but it's very important to know that there are wide confidence intervals on this. So all of these data that we run into the models are all probabilistic models. And it's very hard to say for sure that it happened on this day or even this week. So we believe that it was sometime in January.
And we will come back to you in the future to check in with you, and we'll hold you to this. The next question, James. From what's happened in the past, looking forward, what do you predict?
The safest prediction is that it will continue to mutate, but there's no guarantee at all. In fact, the odds are that there won't be any mutations that make it more virulent, like people try to say. If anything, there could be mutations that attenuate it very slightly. So genetically, we predict that we're going to continue to see mutations, we're going to continue to see spread around the world, and we're going to continue to be able to track that spread through the mutations. But as to any change in the biology of the virus, that is pure speculation, I think, at this point.
But why do you speculate that it might be more likely to attenuate, in other words, become less aggressive?
In general, speaking in very general terms, there's been a history of viruses that if they stay in the human population over time...
So this is the host-virus interaction and we get used to each other over time.
There's a little bit of that, and it's also that there can be selective pressures to favour viruses that are actually not as deadly for their host.
So that they live on in the host to replicate rather than killing them?
Along those lines, yes, but I think we can't hope for that to happen in this case.
James Hadfield, thank you for joining us. It's been illuminating.
My pleasure.
James Hadfield is a phylogeneticist at the Bedford Lab in Seattle. One of Australia's leading intensive care specialists says doctors may have to ration care based on age if COVID-19 cases explode. As hospitals scramble to prepare for a wave of cases, data from Italy and China suggests some tough decisions are ahead about how they treat patients. Professor John Fraser is Director of ICU at Prince Charles Hospital in Brisbane, and he's put in a proposal to the Federal Health Minister for funding which could transform decision-making by intensive care specialists faced with critical ill patients with COVID-19. I spoke to John Fraser yesterday. Bad times.
Not good times, but...
Have you had any cases yet?
There's a number of cases. There's no one in intensive care as of yesterday across Queensland, but there's cases, again, we're connected globally now, so the UK started to fill up. There's a number of patients on ECMO on the UK.
So that's the heart-lung bypass machine?
Yeah, the artificial lung. Lots of patients ventilated.
So how many ECMO machines do you have in your unit?
At Prince Charles, I'm not sure the exact number, but they are increasing them, and across Queensland there's a capability. But the question will be, if the modelling's right, 15-20% of people that get COVID become seriously unwell, whether we'll have enough beds to even think of using them. That's what's happening at the moment in the UK. They're actually talking about, despite the fact we know the artificial lung will work, we don't have enough beds or enough staff. You'll need one nurse, heavy doctor input, heavy perfusionist input, etc. It's expensive. There's only a certain number. So then it becomes distributive justice.
Have you started clearing beds yet?
The group across Metro North, Liz Rushbrook's done a great job. She was military, and I think this is now becoming a military situation.
Yeah.
So it's a case of she's been modelling for weeks, maybe even months. What does it look like when it's 75% surgical capacity, 50% surgical capacity?
You haven't answered my question. Are you emptying beds?
No, we haven't emptied beds yet.
But how quickly can you if it suddenly ramps up?
Well, what you can do is you can reduce the elective surgery. You know, if you've got someone in there that needs intensive care, at least just now, no one's talking about it.
Because what people don't realise is that a lot of people going to intensive care have just had complex surgery and they need to be looked after, and that's the problem, and they won't be treated.
So then the question is, how much of that surgery can be postponed? But normal business has to happen. People will still get heart attacks, people will still get strokes, people will still need big tummy operations. So we can't stop them. What we can do is, the main thing is obviously reduce contact, be remotable. If you can work from home, stay at home. I've sent my whole research team home. Unless you need to be in the hospital, you shouldn't be in the hospital.
The stories here from Italy are that intensive care specialists are making terrible decisions, then it wrecks them. So if you're over 60, you've been put to one side because there are 30 and 40-year-olds dying of this.
The president of the Italian Medical Association died 2 nights ago, 61, 62. We spoke to the president of the Spanish Society this morning. He's self-isolated, he's caught the virus. And this is what's going to happen. What they saw in Italy was about 20% of the medical workforce got infected. So that means you've got a great ICU team of nurses, doctors, allied health, but they got a 20% risk. And then if they're working 7 days and nights, which is what they did in Wuhan, they're either going to catch the bug or they're just going to fall over exhausted.
So what are you trying to do?
I'm trying to show that it's great what Australia is doing in Australia, but this virus...
Is it great? We don't know yet.
They're trying to get prepared. Some of the people are doing the intensive care societies, got guidelines coming out changing tomorrow. People have been buying more ventilators. They've been looking at how can we expand, what's the surge capacity. So that is important. But there's no point just in looking at Australia. This is a global condition. It's a little bit like a global bushfire. And so we need to know as much data as we can, because at the moment this is a condition we've never seen before.
Let's assume that you've got a bed, you've made a tough decision, the 60-year-old doesn't get treated, but the 40-year-old does for various reasons, with better chance on this intensive care. Have you got the other criteria? Because what I understand is that when you look at the Chinese data, and it's apparently very good from the intensive care units in China, we're very sophisticated, is that when they see a 40-year-old die, they haven't got a clue what predicted that. It's not that they've got diabetes and heart disease or obstructive lung disease. They don't know.
The initial story was it was just old people, but that's not true. You're exactly right. There's 40-year-olds, there's 30-year-olds. We need more information, and the only way we can get this is do a global information gathering. We're fortunate we've got artificial learning now, so we've got a whole team based in Sydney and based in Brisbane, looking not at the medical, so we put as much data as we can get from these 24 countries we've got worldwide, over 100 centres, put the data in, and with it, the more data we get, the more the machine can learn, and then we can give you decision support and say, for this patient, you should try this because I've analysed this much data. I don't actually think it's research now, I think it's a public health imperative, because we've got no way of learning this. There's no book I can go to and see, what do you do? Because it's a brand new condition. So we need the money to get a team, because it's a global responsibility that we've got here in Australia.
Why can't we just simply learn from the Chinese and apply it?
Whether we got all the data out of China is unclear at the moment. So it's all about information gathering. The Italian intensive care is fantastic, but they're running out of beds. And then it doesn't matter how fantastic you are. If you don't have a ventilator, it doesn't matter.
So you're trying to get better decision support. So if you're a registrar or a consultant in intensive care, and you're looking at this person, you'd say, look, according to the international data, we can actually keep you in the ward for another 2 days.
Which allows someone that's sicker to go into the intensive care and use that ventilator more appropriately.
So have you had any word about whether you're going to get the money?
No, but I'm Scottish and we'll just keep going. And we have...
It's called heat banging.
Yeah, stitch that, Jimmy.
The Glasgow kiss.
Yeah, but I think it's essential. It may upset politicians, being Glaswegians, we don't mind doing that. Our responsibility as doctors is to get the right thing by our patients.
So how scared are you for yourself?
Yeah, it's an interesting one. I've got 5 kids, and we were chatting about this last couple of days. So,
How old are they?
24, who's an intern at the Royal Brisbane. 22, who's a physio who's going in and out of houses. 19-year-old that's just interested about sport. 14-year-old's very keen that school gets cancelled. And the 9-year-old's just bowling in the back garden. But there is concern, so we're going to have a chit-chat this afternoon about what happens if Dad gets sick, what happens if Dad goes to intensive care, which will be interesting because the 24-year-old's smart enough, but he's not particularly street savvy, so he might be in charge.
I was out yesterday and I was in the supermarket and I just thought, nobody has an idea what's about to happen.
No one has an idea, but the data's there. But if we can't gather it and analyse it, that's our failure.
102 years since we've had to confront this, but you didn't answer my question.
Yep.
It was a very mechanical question, if I might say so.
Yep, go for it again.
Professor Fraser,
Yeah.
how are you feeling about it yourself?
Yeah, it is real.
You scared?
Yes. I mean, I think I'm fit. I'm 51, but I'm on the up flick of the curve. Do you put your children first, which is what you always do when you're a parent, or do you put your patients first, which is what you've been taught to do since you graduated at Baird Hall at Glasgow University years ago? I think you will not find intensive care specialists in Australia not going into work. I think they'll turn up. But it's that I'm going to give my children an extra risk. Is that okay?
And what's it going to feel like when you've got 2 patients in front of you, they've both got 3 or 4 kids, one's 40 and one's 60, and you're going to choose this 40-year-old?
It's going to be difficult. Please God it doesn't get to that, but it can get to that. I don't know. I've never been faced with it before. And this is why it all comes down, I sound boring like a broken record, but it all comes down to getting as much of a global experience together to know what to do. We spoke to the people in Canada there, they've joined in as well, and obviously the SARS epidemic. And one of my colleagues during the SARS epidemic had to do exactly what you've said, and they picked this patient, not this patient.
This was in Toronto?
Yeah, and he was then charged with manslaughter.
You're kidding?
Charged with manslaughter because he made a decision, this one. We don't know. There was no class at uni to tell you how do you pick A or B. But it now becomes a military situation when you go out on a triage situation and you say this one is salvageable. We're not there yet in Australia. I think the key thing is we don't panic. We prepare for the worst, but we hope for the best. And that's hopefully what we're doing here. But we do need to take this as a global condition and we need to look at it in a global nature.
Now, we're talking at a point in time, and the government's just said, well, from tomorrow, meetings over 500 people are not going to happen. So I can take from your raise of your eyebrows, you think we're doing too little, too late?
Too little, too late. Korea did a great job, except for one person who was what's called a super spreader. So one of the crazies from the church down south knew she was unwell and kept going to gatherings. It took one person that became a super spreader. So if you have, yes, 500, someone's picked a number. Normally, I'd suck my thumb, but I wouldn't today. You pick a number and you say that's a reasonable number. All you need is one person that's infected to cough over you. And 500, the risk becomes exponential. But I would suggest much less. I stopped my kids playing rugby yesterday, which was devastating for them. Because rugby, you're in such close proximity. 1.5 metres, you're 1.5 centimetres away from someone's breathing. So I said, that's off. Cricket, the wee man allowed to play cricket. I hate cricket.
Scottish,
and I isolated myself. I was the unfriendly parent that stood down the back of the pitch and told them. But the kids did get to, fist bump and all these things.
Well, as they'd say in Glasgow, good luck, Jimmy.
Thanks, I need it.
Certainly does. John Fraser is Professor of Intensive Care at the University of Queensland and is at Prince Charles Hospital and St Andrews Hospitals in Brisbane. You've been listening to The Health Report. I'm Norman Swan. See you next week.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio and exclusives on the ABC Listen app.